Hello, Assalamu alaikum, dear students. How are you? I am Dr. Jamil Abbas from Physiology Department, and this lecture is in continuation to your previous lecture that is concerned with the counter current mechanism. And today I am going to discuss the role of vasarecta, role of the vasarecta. This is written as this vasarecta is written as. Please just wait. Now you can see this is the vasa recta. This vasa recta in brief is written as the VR. This is actually the extension of the peritubular capillary network. So this vasa recta is the extension of the peritubular capillary network of a very special nephrons, juxtamedullary nephrons. These nephrons, they are very close to their glomeruli. They are found very close to the juxta means near. They are very close to the medulla. So their role in the counter current mechanism. Now you can look at the diagram. This diagram says this vasa recta is of same shape as that of your loop of Henle. And this U-shaped tube is very important for the maintenance of the hyperosmolarity of the medulla. As I've told you in previous lecture that hyperosmolarity of the medulla is studied in three steps. First of all, how it is formed or created. Second step is how it is maintained. The first step we have done already, that was it is created due to the accumulation of the sodium and the urea basically over here in this intermedulla, in this area, in this interstitium. Then we are going to look at how it is maintained. Once it is formed, then how it is maintained. Actually, the problem is that as we move deep into the middle, the blood supply to this area is far less as compared to the rest of the kidney. This area of the medulla, you can follow my cursor, this area receiving very small amount of blood as compared to the rest of the kidney, and this is less than 5%. You can see over here, this is less than 5% blood is reaching over to this area. And this less blood, that means this area is already supplied with a very less amount of the blood. But to provide oxygen to this area, although we are supplying the blood to this area, but we are supplying the blood, but at the same time we are trying to maintain the hyperosmolarity of the medulla. That means the sodium and the urea which are getting accumulated over these sides, this should remains there. Maintenance means this urea and the sodium which are already present over here, they should not be drained from this side. They should be retained over here. Now, as you know that the capillaries, through these capillaries, solutes and the solvents, they can pass in or out anywhere, no problem. But the only thing which is going to decide that which thing should be moved out and which thing should be moved into, that's the only and only the concentration gradient. This is the concentration gradient which will decide that which thing is allowed to move out and which are the things which are allowed to move in. Then these capillaries, they are highly porous. These are highly porous. That means everything can pass out or in except proteins. Proteins are not allowed to move from this side to this side. Mainly the albumin. I am talking about the albumin mainly. Now the concentration gradient is going to decide which thing will move in and out. Now suppose my cursor is, this is your proximal tubule, and we are entering from the tubule having this osmolarity of 300 milliosmol, and we are entering into the descending limb of loop of Henle. My cursor is moving into the descending limb of loop of Henle, and we have got the fenestrations over here. Now as we are moving down outside, as we are moving down, more and more solutes are present here. So solute will begin to move inside. So from the interstitium, as the as the filtrate begins to move down, solutes will begin to move into the descending limb of loop of Henle, because solutes are more over here and less here. At the same time, you will see, because solutes are moving in here, we have got more solute at this side, so water will leave out. Forget about this arrow at this moment, this arrow, forget about this one, just concentrate on this arrow. So two things are going to happen over here. Solutes, they are moving in because solute has got more concentration over here and less. Water is moving out, but solutes are more. That's why water is sucked by solutes over here. So as we are moving down again, more solute will move in and more water will leave out. So the same thing is going to happen as we move to the bottom, deep. More solute will move in, more solute will move in, and the water will move out until we reach the maximum point, or you can say the deepest point in the medulla. Over here, the osmolarity is 1200 milliosmol. So here, the concentration of solute in the interstitium and the concentration of the solute over here inside will become equal. So when they become equal, when they become this concentration, when it will become equal, there will be no further movement of the solute from this side and no further movement of water from this side. Now, after that, the solute, it will take a loop of, along with the loop of Henle, it will take a U-turn. This is loop, your vasarecta, it will take a turn, that is a U-turn. Going back from inner medulla is going back to the cortex. It is going to move to this cortex. So let's start from again from the deep side. Now it's moving up. As we are moving up, now here we have got the maximum solutes. As we are moving up, solutes concentration are less. Inside the solutes are more now, because solutes are accumulated from this side to this side, and we have got maximum solutes over here. Solute means mainly your sodium, urea, mainly your sodium and the urea. So as we are moving up, solutes will move out, and now the water will re-enter into the loop of, into the ascending part of the vasa recta. So as we are moving up, more and more solutes are moving out and more water is again entering. More solutes are moving out and water is entering. Nutshell is that when we are moving down to the vasa recta, it is solutes are entered over here, but as we take the U-turn and going back to the cortex, all the solutes which are coming from this side, they are going out from this side, and water which is leaving out from this side is going to re-enter over here. So net shell result is the solutes which are moved in, they remain the same way. They remain there. Once they enter, they leave out. So solutes, they are retained over this side. The concentration of solute on this side is not going to be disturbed by the time the blood is supplying oxygen to this area. So the oxygen supply, or the main nutrients, they are supplied to this area, while the concentration of solute is not going to be changed, or you can say it is maintained due to the this movement, due to the loop of, due to the U-turn of vasa recta, due to the permeability, and due to the concentration gradient formed as we are moving down. This is very important, because I was saying first that this loop, this vasa recta is responsible for the maintenance of the concentration gradient in the inner medullary interstitium. The concentration gradient over here is maintained by the vasa recta. So the blood supply to this area, although the blood supply is far less, second very important thing, the blood flow is very slow over here. Blood flow is far slower as compared to the rest of the capillary. So it takes a good time for the movement of solute in and out of water, again movement of solute out and water in. So by the time we reach it to this area, you will see, you can compare that here we have got 300, here we got approximately 350, some books say 320. So very small amount of sodium and the urea, they do leak out by that, sorry, they do move, they are very very small amount of fluid, sorry, solutes, that is sodium and the urea, they definitely moved out, but majority, or you can say more than 99% of the solutes, they are remained here. That is, despite of the supply of the blood to this area, despite supply of the nutrients to this area, but the concentration of solutes and the solvents is not going to be disturbed. One thing, that means how it is going to be maintained. Second thing is that if there is a hypertension, the patient is suffering from the high blood pressure, definitely it will cause the increased blood flow. Speed of the blood is become more. When the speed become more in this area, so blood will come with a high speed down and move out. During that high movement, it will drain some of the solutes from this interstitium into the medulla, into the cortex. So it will cause, if there is a high blood pressure and there is a high speed of the filtrate into the vasarecta, definitely it will cause the drainage of the solutes, drainage of the hyperosmolarity medulla, mainly the sodium and the potassium, it will be drained from this area. And when this hyperosmolarity is reduced due to the drainage of the some of the sodium and some of the urea, due to the decrease in this hyperosmolarity of the medulla, the patient may, if we have lot of ADH, even then patient has to pass dilute urine. So that means more urine with a less solute. Secondly, if you give the vasodilator drugs, if the patient is receiving the vasodilator drugs, that means the vessels are going to be dilated. If the patient receiving such drugs, definitely it will also increase the blood flow into this area, and it also drain some of the solutes from here. And when the interstitium hyperosmolarity is reduced, then the patient may pass more amount of urine, that means the urine having more water and less solute. So these two things, the vasodilatation, drugs causing this vasodilatation, the hypertension, in those two conditions, the patient may loses this hyperosmolarity of the medulla. And this was all about the role of the vasarecta. In the next, we are going to see the role of the ADH. Thank you very much.